Анна? Анна, вы меня слышите? Кто-то из техников, ответьте, пожалуйста.
Ну, у нас же все лечится пластырем.
Я не знаю, у меня тут ничего не включается. Алло. Так, слушайте, ну все, идите, вас примет Антонова Ирина Владимировна. Ищите на отделение Антонова. Антонову. Ага, все. Ну так что мы начинаем?
Да.
Что?
Ты спросить, можно начинать? Нельзя? Техническая служба.
Техническая служба. У меня к вам вопрос. Можно начинать? Здравствуйте, мы начинаем российско-сербский.
Dear colleagues, we are starting a Russian-Serbian symposium. The topic is the role of neurosurgery, and the topic of today is what is more important, the heart or the brain. So from this moment on, I would like to give the floor to our esteemed colleague from Belgrade, Danica Grušić, and all Serbia knows her, and she is known in Russia as well. We decided to give you the floor first because we know that people always need you, and I believe that your patients are waiting for you, so that's why we are starting from you. So the topic of the report is, Danica, we cannot hear.
Так, вот интересно.
видит.
Да, но не слышит.
Видит, но не слышит.
Так, что будем делать?
Ну, мы можем пока начать, пускай тогда Мария Ильинична уже вроде пришла.
Даника, вы готовы?
Вы меня слышите, Любовь?
Can you hear me? I can see you and hear you, so it's great.
Секундочку, Даника, вы выбрали язык?
Даника, вы готовы к докладу выступить первой? Слышите меня? Слышите меня? Слышите меня? Слышите меня?
И так 3 раза.
Вот так.
Нет, все-таки нужен лейкопластырь, я думаю.
Даника, вы выбрали язык? Я не понимаю, что вы говорите, потому что эхо очень большое.
Техническая служба. Мы не слышим друг друга, и еще к тому же эхо.
Даника, здравствуйте. Вы выбрали
язык.
Да, по-русски попробую. Я же в
А
второй части, да?
выключите,
Около
выключите
2 часов,
оригинальный
да?
звук.
Я попробую. Слайды будут по...
Все, теперь мы не слышим. Мы не слышим.
Russian. Я выбрала. Там же оригинальный mute original audio. Mute. Хорошо. Сейчас все хорошо? Вы слышите меня?
Поехали.
Можно и Даня. Все равно.
So we give the floor to Danica Grucic, and she's the first to speak in this section. I was planning to do this last. Good. I'm going to be here all day because all the topics are really of great interest to me, and I would like to listen to all the reports. So great, we are starting. And the first report is epilepsy. So we flip a little bit, and are we completely lost, confused? This is the topic of the speech. And the presenter is Maria Fomina from St. Petersburg.
Это же он?
Нет, это Мария.
Во, все, нашла, спасибо. Нашла. Сейчас, извините за сумбур.
Sorry for the confusion and technical problems.
Давайте сначала. Ну, уважаемые коллеги.
Dear colleagues, Dmitry has formulated the topic in a philosophical way, in a philosophical key, and I'm going to try to follow his footsteps. Taking into account the audience that we have today, we'll start with the classification of epilepsy and those diseases that you face and work with. As you see, in 2017, the classification has been adapted and up-to-dated, and we eliminated a number of old terms, and we know today that different groups of epilepsy that we called syndromes before, these are structural epilepsy and genetic epilepsy, metabolic, immune, etc. And we have an opportunity to go back to cryptogenic and undetermined epilepsies. If you see a patient that you have studied and examined thoroughly and you haven't understood what it is, you can say it's undetermined epilepsy. So it's focal epilepsy and generalized epilepsy. So I'm passing on to two major issues of modern epilepsy. The most difficult thing, if it is an epileptic seizure or non-epileptic seizure, and we're speaking about children now. In children, we have a number of different diseases that involve movement, and in adults as well. So our aim is to understand what kind of etiology it is. Non-epileptic paroxysm is a huge group of neurological diseases. They are benign by their nature, and it is really difficult to diagnose them. According to different scientists, neuroleptical seizures are seen in 1 to 4 or in 1 to 500 children of early age. Wrong diagnostics of these conditions bring to inadequate therapy. And we have analyzed a lot of patients, and it is really important to state what a diagnosis is, a correct diagnosis, and to select a strategy for treatment. So International Imitators of Epilepsy, it's an international anti-epileptic league, and we differentiate different kinds of seizures. It's syncope and anoxic seizures. So the first subgroup, it's a huge subgroup, vasovagal syncopes. It's different types of syncopes that some of the patients have with cardiovascular diseases. It's orthostatic problems, some cardiac issues, etc. The second group is even more complicated because it involves behavioral, psychological, and psychic diseases. It's panic attacks that you come across very often in your practice, and different dissociative disorders, etc. Further on, a huge group is different conditions related to sleeping. Of course, I cannot mention all of them. Parasomniac conditions, REM, and then benign neonatal myoclonus of sleep, and a lot of children, newborn children, got therapy for other conditions because it was not diagnosed correctly, and this condition doesn't demand any type of treatment because the condition, because of treatment, becomes even more serious, because the third and fourth stages of sleep are prolonged, and the child even has more seizures. So another subgroup is a different type of tics, and we cannot really tell one from another, and it's one of the types of movement disorders, and it's not really easy. Newborns have hyperexplexy, paraneoplastic dyskinesia, and it's a whole variety of diseases. Migraines and headaches are also a number of diseases. They include different conditions in early stages and early ages as well. It's in adult conditions, they're determined by a number of factors, also family, etc. And in the perinatal center, we have a lot of weird kinds of movements of newborns, some movements of head, etc. And we need to do monitoring. And I divide them by age. It's benign neonatal myoclonus. It's first 2 months of life, and then it becomes more and more complicated. It's different types of syndromes on the first year, and it demands surgery. And it's different kinds of seizures that demand correction, and you need to think and reflect upon this further on. It's a classic example that I'm going to provide. Hyperdiagnostics is also not a way to treat it. So we had a patient. So the parents were saying that she's becoming still, and she's folding her hair with her fingers. So we have a video here. I cannot switch it on for some reason. So you see a child. She's wearing a hat, and she has a generalized epileptic form epileptic-like activity, and because she couldn't touch her hair. But her development was normal. Yeah, I cannot switch on the video. Okay, we skip the video. So then she becomes still, and then she has a generalized seizure. She didn't have tics, just these kinds of conditions, and vice versa. This is a newborn child, and it looks like an infantile seizure, but it's a typical seizure. He's folding himself, you see, and he has a syndrome, a West syndrome, and he was receiving therapy. So he was doing this during the first 3 months of his life, and it's cluster spasm, basically. And yeah, he had an myographic artifact. It's a series. It's a syndrome of Fijerman. It's a benign condition. The second option is pharmaco-resistant epilepsy. So the first issue is to define epilepsy from non-epilepsy, and the second issue is pharmaco-resistant epilepsies. We have discussed this issue a number of times. It's a really complicated mechanism, and your students, future doctors, are going to try to understand what it is like. I'm going to just draw major characteristics. It's pharmacokinetics, genetics. Great role is given to neural networks. I'm going to speak about it a bit more. What is pharmacokinetics, and what is drug-resistant epilepsy? So subtherapeutic level of medicine brings to resistance, and then there are some kinds of particular features related to age, for example, a young age. So you need to control plasma concentration, use medicine in line with pharmacokinetics, and use individual pattern for each patient. The seizures change the elasticity of the brain and cause synaptic changes in the brain, and the abnormalities are formed. So this neuronal network develops resistance. So it's a complicated mechanism, modulated by different kinds of conditions. And epileptogenic brain, which is seen as a pathologic sprouting when different kinds of exciting networks are formed and the common networks are not formed. So if medicine is prescribed immediately after the seizure, so it's 40% effective, and later on, after 6 months, it's only 22% effective. We need to do MRI imaging and see the brain, and so further on, pharmacoresistance is also influenced by the disease itself, etiology of the disease, and the condition, how grave the condition is. Epilepsy can be genetic. The pathology of channels is one of the. So Dravet syndrome. Bromides work well in this condition. Heterodrotoxin, it blocks receptors, and it comes from the spiders. Ataluran is applied in one type of epilepsies, and so we thought we might apply it for other types, and it works. Ganaxolone, it's experimental medicine, but as anti-seizure medicine, all these medications are useless. Memantine works well. Memantine was effective. The theory of inflammation also has its place here when we speak about epilepsies. So everything that is modeled through cytokines, through cycle of oxygenase 2, which means chronic inflammation in central nervous system.
We start this pathology process, and then we use the following drug. Celecoxib is inhibiting cyclooxygenase 2, and it does work in cases of some resistant epilepsies. Here are the links so that you can later dive into the material. As for the genes, well, just to familiarize the audience, I have placed the most frequent genes that are associated with epileptic syndromes. If you regard them, it's mainly the lesions of channels. Everything malignant in newborns is related to potassium and natrium channels of newborns. For example, Dravet syndrome, there are two main mutations: absence epilepsy with febrile seizures plus that's GAB subunits mutation, etc. That's just for your consideration, some ideas about the genetics of epilepsy. When I was preparing this presentation, I looked at the materials. There were 56 mutations, now 69. More and more new genes are being mapped. It's a speedy process. Well, here comes the main idea. Before we treat somebody, it's good to study their genetics, and if it's an inborn epilepsy with there are some 30-40 markers of mutation, then complete exome sequencing would be of assistance. As for the target therapy, it depends on what you find, on what you diagnose. If it's the different kinds of channels, different drugs work. And there's a rational explanation for that. Here are the main mutations on this slide and the relevant drugs. I exclude the specific syndromes and lysosomal, for example, accumulation diseases. Now there are special drugs of choice. Now regarding the genetics, again, we found very distinct correlations between the natrium channels polymorphism, that's gene SCN1A. It's associated with the relevant syndrome in newborns. Its mutations provide resistance to carbamazepine, so don't you use it for newborns. And this is a reason for consideration, and the main thing was to prescribe universal drugs with combined activity. Next is the transport hypothesis, the models of epilepsy. It's really very demonstrative. There are systems that P protein, the transport protein that brings the matter from one cell to the other and does not let it accumulate or brings it out. That's the multi-drug resistance mechanism, which is coded by certain genes. P protein coding genes. They thought what's to be done with that, so they have provided the drugs that inhibit that P protein. They first thought about it for rheumatoid arthritis and then used it for epilepsy as well. I wasn't given much time for my presentation, and I did try to squeeze everything I wanted to mention in 15 minutes. Nowadays, epilepsy is quite a huge group of nosologies that should be treated in different ways, not only with valproate and carbamazepine. There are options. I'd like to thank the organizers for giving me the floor. If questions arise, I'll be happy to answer somewhere in chat. Please don't leave. Stay with us. Could you please tell? Gene multifocal pharmaco-resistant epilepsy. Any prospects for surgical treatment of that? There are certain syndromes associated with focal cortical dysplasias. There's plenty of those. VCD in the structure of many genetics syndromes is frequent. Yeah, probably yes. If the substrate is present, then surgery is okay. Also, agenesia over the certain body. 80% of that is associated with epilepsy. But in case of genetic epilepsies, surgery is not a choice. I have a question. So the topic is brain or heart. It's not by chance that, corpus callosum, that's what was meant. We have a notion called lesion of channels, and there may be a sudden cardiac death caused by that. Same genes, same mutations may cause the channel lesions in the heart. Do you do heart monitoring for children with already clear genetics? Yes, sure. The sudden cardiac death syndrome happens in both children and adults. We do the ECG or we adjust the heart monitor. We know that carbamazepine may cause the lesions of heart, so we do check that. Are there many children of a kind? The more we check genetics, the more we find. There is quite an association, very frequent, these heart lesions and epilepsy, or asthma and epilepsy. These are interrelated things. It's very seldom that we get such an expert, so we'll keep asking questions to you. Please stay. What's your attitude to the surgical treatment of MR-negative epilepsies? I believe if there's no morphology substrate, perhaps I'm not an expert in surgery, but my opinion is you have nothing to cut, no surgery with no, severe meningoencephalitis with tonic seizures. And after the surgery, some seizures stopped, but the girl doesn't collapse. That's it. It's only palliative surgery that may be prescribed. Otherwise, it's not a treatment. I will make a selection of my patients that have had the surgery, and we can check. For example, Lennox Gaston, from despair, they did do surgery. There were seizures with falls and concussions. That's why they used surgery. Surgery as palliative treatment. That's it. Yeah, I quite agree with you. Is that a discussion? I believe, yeah, if it's either VNS or palliative surgery. If the person feels better after that, for prevention of falls and traumas, perhaps. Okay. We'll think about MR diagnosis, but I'm also negative about resections in cases of epilepsy. They monitor, they look for loci with EG monitoring. They consider the risk. I quite agree. If you find the loci or focus, you do have to prove that this is the reason. I'm talking not about the MRI, but about the EG. You found the foci, the child has a seizure, but you have to prove that this is the zone that causes it, and it has to have an impact. Any more questions? Thanks a lot. The next presentation is on hemorrhagic stroke, the role of a neurosurgeon. Dmitry Alexandrovich, our chief surgeon from the healthcare ministry in the northwest of Russia. Well, as one of my teachers used to say, this presentation is mainly for the youth. There's Professor Alyoshin. That's what my teacher, he will tell about this for the user, because the experts know about that, and they know about hemorrhagic stroke. I will mainly talk about the hypertension, intracranial bleeding. It's a very severe complication, and it's 10-20% of all the cerebral strokes. Some 50% die within a year, and 5 years survival doesn't exceed 30%. Quite bad figures. They tell us, neurosurgeons, your patients don't live long, they have tumors. Well, these patients are even worse, and neurosurgery doesn't suit them. Well, we're trying to help for these patients, but that's rather emotional. And let me I'll later tell you about the history of the issue. The attempts to rehabilitate the methods of treatment with low efficacy get repeated every 30 years. The primary and the secondary, that's classification. The primary is hypertensive, intra-brain bleeding, cerebral amyloid angiopathy. We know how to treat that. Secondary arterial aneurysms and AVM. As for the coagulopathy, vasculopathy, everything is clear. The role of surgeon is pretty small in such cases. And if we get a patient with a bleeding disorder, iatrogenic, or in case of leukemia syndrome, the basic disease, there are disputes on what to start with. We're trying to form a hemostasis. We took just organized coagulation for that patient. Why surgeons are the scapegoat? Well, when being young surgeons, we didn't want to avoid that. But everything is clear. The intracranial pressure goes up, the Monroe-Kelly doctrine, and if a certain substrate gets bigger, the substrates get smaller inside the brain. Local compression of non-damaged brain and the routes, cytotoxic edema in perifocal zone. Well, terms are beautiful, but let's simplify. This is a hematoma which is poisoning the brain, and there's the decline of the local and systemic perfusion. That's the image. Oliveira name is well known to neurosurgeons. One of the most favorite names, Oliveira the Younger, that's his image. And with the help of this scheme, we explain what I mentioned in the previous slide. We should pay attention to the following. It's the secondary lesion of brain or the secondary trauma, which is getting worse after the bleeding and makes the forecast worse. Well, what's to be done? The situation is pretty clear. This is a hematoma, a kind of a ball, additional mass in the head, and you want to remove it. Thus, you'll get rid of edema, dislocation, and high intracranial pressure and the poisoning of brain, but it doesn't work, however. For many years, this is the updated randomized study. But yet in 1950s, 1960s, they started to study the issue. And the study stage 1, stage 2 provided very clear information. They didn't manage to prove that the surgery improves the quality of life or the results of hemorrhagic stroke. Surgery, evacuation of hematoma, or conservative treatment of patients didn't work well enough. Just in the first study, they proved that in young patients, in case of lobar hematomas, the subcortical ones, one can get certain improvement of condition. Later, they found out that 1/3 of those patients, the bleeding wasn't caused by hypertension, but some other malformations, and that's a different disease, different forecast, and different risk factors. So, seems like it was hopeless. There was a logical doctrine, but it didn't help, didn't impact anything. Well, perhaps trepanation could help. The skull trepanation after the age of 50 may cause certain complications. It's difficult for the patient, even if you don't impact the cerebral brain. It will worsen the forecast, so it shouldn't be done. Hematoma is rather deep, some of them said. On the way to get it, we may damage some vessels or healthy tissues of the brain, so we'll traumatize brain even worse and worsen the forecast. Some said about pain-killing narcosis. It's bad for elderly people. It doesn't work well. Hence, again, the situation wasn't clear. And again, neurosurgeons thought, everything is about the size. If the aperture is small instead of big, then the trauma shall be smaller. And also, if you don't insert tools into it, it will be better. So no iron tools. Let's use a thin wire through a thin aperture. The results shall be better. So they were trying endoscopy, portal surgery in a water environment, etc. There was a special device, a patented one. It was called Napola, I believe. Later it was renamed. It was like a big washing machine with two tubes, one providing water, the other aspiring it. And they've organized a multi-center study, but nothing worked. And recently, in the year 1920, 78 hospitals participated in the study MISTI 3. They used a catheter, stereotoxic targeting, and different solvents were used to remove, to dissolve the hematoma. They used ubiquinase and other drugs. The conclusion was excellent. In some cases, this method may be safe. Well, in fact, there was a big discussion in literature about it. We also made experiments on people in 2 clinics. I'm not naming them. since not a single drug is registered in our country. It wasn't legitimate. No drugs are registered that could be introduced in the brain. We didn't participate in the study, and we didn't have the right to do it. However, nothing worked, in fact. And now there's another study on small craniotomy with a stereoscopic expanded port, so we continue the study. What can we do in case of such hemorrhagic stroke? We can do the drainage of lateral parts. If you did the drainage, surgeons know that it's a wrong idea, because no tube can remove this part of hematoma. It didn't work at all. You couldn't remove it from the ventricle. You need to wait till it dissolves and disappears. As for using the pressure, interesting thing, if you ask the therapist.
So, are you going to treat high pressure without measuring arterial pressure? Then any person will say, no, we cannot skip this stage. Yeah, we need special equipment for that. But intracranial pressure is treated without measuring this type of pressure in any way. We don't have sensors in no intensive care unit here. So it doesn't really help. When we use surgery for elimination of hematomas, it doesn't really help a lot. The third possibility is non-surgical treatment when you make a window with the diameter of 5 millimeters. It's not decompressive craniotomy. It's something different. Decompressive craniotomy, it's a window. Some people think that it will make the chances of the patients to survive. When I was preparing for this report and collecting materials, I have postgraduate students that write thesis on it. I came across a curious fact. In 1963, academic Shamsov, he was, and Ugrumov was working as well on the basis of Mariinsky Hospital. Now, there was a neurovascular department, the first in the Soviet Union, and it was related to the Pediatric Institute in St. Petersburg, so this name is really important to us. This year, it's 60 years anniversary of the vascular center that was founded in the city here, Leningrad, and it was very effective in its activities. And all these centers that were created recently, I do not want to use this word, but it's a copy of that center that was founded in Leningrad. A neurosurgeon, he accepted all the patients with strokes, and then he differentiated different types of strokes, hemorrhagic, ischemic, etc. And so patients with stroke went to neurological department and others to other departments. So Boris Nikiforov initiated the creation of emergencies and neurological brigades, and he wanted to promote the specialized help to neurological patients. He established indications based on a serious analysis, and Boris was a talented person, and he was born in Shanghai, and he graduated from French university there. And then when he became a professor, he didn't want to receive it. All the lectures that he delivered, the history of the party wasn't there, and he had to pass this exam in Moscow. So we were quite young at that time, and we were active, and we were unhappy with the fact that the professor didn't let us operate hematomas, and we were aggressive. So this is our clinical example, the portal access. Our colleagues in Cheboksary make this type of surgery. This is a conclusion of the American Association of Hemorrhagic Strokes as far as surgery is concerned. For most of the patients, the use of surgery is not clear. What is clear and transparent that people with bleedings, with hydrocephaly, need to be to undergo surgery as quickly as possible. And the surgeons know why some types of operations are counterindicated. Patients who have huge hematomas, more than 30 millimeters, the distance of more than 1 centimeter from the surface of cortex are not indicated. The effectiveness of minimally invasive methods of elimination of hematomas and implication of stethoscopic or endoscopic aspirations is not clear and demands further study. And in spite of theoretical attractiveness of the idea of early elimination of hematomas and positive forecast, when we make MRI, we see after this type of surgery that there is a bigger hematoma than the one that we have eliminated. So the patients, so when we treat the patients with the traumas or vascular diseases, we actually treat not specific disease, but the whole disease that who has negative forecast, and no surgery doesn't have impact on lethality in a vascular center. That's it for now. Thank you very much, Igor, Dmitry Alexandrovich. Does anyone have questions? Then I got a question. Okay. Ischemic stroke is better than a hemorrhagic stroke. Is that so? It's just to sum up. So, hemorrhagic stroke, is it better or worse than ischemic in terms of forecast? There is a neurosurgeon who used to say, good clips is better than something else. Bad clips is good, but still worse than fishing. And it's a practical joke. So it depends on etiology, genesis of the disease. Patient with ischemic factors can have different conditions. The volume of hematoma, the type of bleeding, the age, concurrent prognostic factors on the stroke is the volume of hematoma, age, and the level of. And we know that these are the factors that play an important role. Older than 60, it's useless to have a surgery, and younger than 60, you do not need to have surgery because those will die anyway, and these ones will survive. But hemorrhagic stroke is treated really difficult. The brain is not muscular organ. It's not the heart. Yeah, we have this topic, heart or brain. There have been studies if there is a dependency between stroke and hematoma. As far as this last research is concerned, so the medium average time from the from the onset of disease to the beginning of surgery, it's 56 hours. There are surgeons who think that the earlier we start, the better, and every milliliter of blood that we evacuate on some stage gives additional chance to the patient to avoid some drastic conditions in the future. But we need to have a demarcation of this zone. Hemostasis needs to take place. In this study, there have been patients that had open surgeries, and there were hematomas that threatened to life. So, what is the timeline for this process? Yeah, I would repeat myself. Thrombolysis is prohibited in our country, so we have some underground experience, personal experience, but it's not acute period. According to the protocol, all the patients were conscious, and they even signed the agreement for the treatment. But still, this is a patient with high potential for getting better and life, and they might move to the bed side, and something needs to be done in this case. So, if the patient is compensated, it should be higher than 8 in the Glasgow scale. He should be compensated in different somatic signs, hematologic as well. Then he might undergo invasive evacuation. It needs to be done in a good way. So our Moscow colleagues have decided that it shouldn't be done in the first 24 hours, and our Leningrad colleagues had the same conclusion, and hematoma shouldn't be eliminated as a whole, and some of it should be left inside. But in 2018, in 2020, yeah, we actually came to it as a practice, but the Leningrad school was the first to speak about it years ago. I do not have questions. I do agree with the colleague. When I was a young neurosurgeon, I felt like operating hematomas, but then it seemed that the quality of life of these patients is really bad, is really low, and I agree with your recommendations. Hematomas of different areas, they can be operated, but then it depends on the patients, on the conditions. Yeah, most of the patients have some systematic disease, and you do not need to evacuate all of hematoma. Minimal invasive methods maybe. Yeah, I belong to the older group of neurosurgeons. I think that you need to enter hematoma and then do hemostasis. And so the next report is. So who is going to be the next?
Анна Федоровна. Нечаянно, Анна Федоровна, как бы такая интересная тема. Диссертационное исследование было посвящено осложнениям
So the next study is devoted to some pathologic conditions with neuro patients. I would like to present our report, a cardiac patient with neurosurgical pathology. Neurosurgeons more and more often come across with patients that receive long-term anti-thrombosis therapy. And these are patients with different diseases, such as mechanic prosthesis of heart valves, fibrillation, etc. On the one hand, anticoagulants bring to high risk of hemorrhagic conditions, and thromboemboli of lung artery is one of the main reasons of lethal of death in neurosurgical patients after the surgeries. According to different evaluations, these conditions are quite often do take place quite often. The main risk factors are ischemic stroke, old age, genetic abnormalities, etc. Hemostasis in our patients has its impact to the condition on the condition of patients, and the risk of bleedings associated with them. It especially goes for the surgery of tumors of the brain that is related with the to the coagulation, and 30% retain this or that form of invalidity. The main mechanism responsible for primary or secondary problems is hyperfibrosis, and it's then drugs that the patient is taking increase the risk of uncontrolled bleedings during the surgery. How can you help these conditions? The most important thing is pre-surgery preparation of the patients, screening, laboratory examinations, and when some kinds of issues occur, we need to stabilize hemostasis. This is a hypersensitive but low specificity characteristic. So we do screening of vasculars. Then we use thromboelastography. It is prescribed before the surgery, during the surgery, and after the surgery. So when there are issues related to coagulations, we have a chance to correct it. the risk of thrombosis of inner deep veins needs to be evaluated before the surgery and after the surgery. Oncological patients have a special scale that is used, but it might be not correct, and the patients with the malignant tumor, they have generally weak psychosomatic condition. They need chemotherapy and they take steroids, and it enlarges the risk of thrombosis. About 80% with the malignant tumors of the brain with the venous thromboemboli, and 47% of patients had these conditions in the first 6 months after chemotherapy. 5 to 16% of patients had thrombosis.
Medication prevention of thrombosis are just elastic underwear and compression and bandages. Pressure. What shall we do regarding the conservative prevention of thrombosis, thromboemboli? On one hand, we need to do a prevention of thrombosis. On the other hand, there may be hemorrhagic complications that may be fatal. On the basis of the existing recommendations or guidelines and the experience of our department, we conducted over 5,000 surgeries in the last 5 years. So now we know better about the prevention of thromboembolism in surgery patients. And this is the scheme, the table, explaining how to do and what for what patients. We've subdivided the surgery patients into 3 groups. Depending on the surgery, spine surgery, vascular pathology, and oncology is subdivided. Benign and malignant tumors. These patients need thromboembolism prevention most, but they also are at the highest risk of hemorrhagic complications. Average risk are the patients that may be prescribed low molecular heparin and at high risk of thrombosis in 48-72 hours. In case of spine surgery, these are patients with no damage of the heart-brain cover, and the patients with radical surgery. In case of malignant tumors, only in case of total removal excision after the good CT with no hemorrhagic complications. Individually, this may be regarded, and we can provide prevention of thromboembolism. The biggest questions are in the high bleeders, risk of bleeders. Individual decisions are to be made. In case of malignant tumors, the contraindications is non-surgical tumor, bleeding into the tumor, or presence of dyschemias. Thus, we have less complications of a kind, twofold at our department, less thromboembolism. However, it remains a serious risk and problem. I've mentioned that low molecular heparin prescription is possible in case of good intra-operation, intra-surgery hemostasis, when we're sure that it'll work. During the surgery, we start the hemostatic cascade. There's vascular constriction, the clot of thrombocytes and fibrins is being formed, and fibrinolysis does take place. Antithrombotic drugs stop the opportunity of the body to create thrombs. And as for the hemostasis, we can influence it from the reverse side, in a reverse method. Here are the examples of hemostatic agents that may impact the thrombine and fibrine clot. In conclusion, I'd like to say that neurosurgery are a special group of patients. The common guidelines for prevention of complications of thrombosis are not cannot be used for them because of the high risk of bleeding after the surgery. If you want to restart this anti-thromb therapy, you have to have the individual approach to every patient, and you have to have a team of neurosurgeon, cardiologist, hematologist, and to keep the balance between the efficacy of antithrombotic therapy and its safety. You should minimize the risk for both kinds of applications, and you should do the close follow-up of patients before, during, and after the surgery. Thanks for the attention. Any questions, colleagues? So shall we prescribe it or not? We need an individualized approach in each and every case. We have presented the table that we are using to find the method. We need to assess the risks for each patient separately, the risk of thrombosis and the risk of bleeding. Would you like to comment? Irina? Not really. The answer is not coming into the mic, so it can't be translated. Apologies. Any questions from you, Tatiana? Danica? No. I'd like to share our experience in Belgrade. We had many thromboembolic complications 3 or 4 years ago. After that, we started to act in a different way, not the way the young doctor has explained. We started to give low molecular heparin to everybody. Hence, we had more post-surgery hematoma. So I do quite agree with this lady. Individual approach is necessary. And if the neurosurgeon believes that there should not be the usage of heparin, you should listen to him, because otherwise the patient will have again a hematoma and again a surgery. Thank you very much. Be happy to give the floor to Professor Irina Savina. She is the Department of Manevsky. I like the word MAPO, that she's coming from that medical institution, and she's an anesthesiologist. She's the professor of the Department of Anesthesiology and Resuscitation and pathologist. Dear friends, distinguished presidium members, I'm happy to share our experience and interesting findings that we have. And we can tell a lot about the interaction between the brain and the heart. Not sure about the colleague from Serbia, but I'll talk about it a lot. Brief comment, prevention. The problem of thromboembolic complications is very serious, and it's huge in intensive medicine. There are important European and American societies, like the one of anesthesiologists and intensive medicine. Thus, they've developed their own guidelines. The year 18, that's the latest guidelines regarding neurosurgery. Not much is written, but yes, the level of evidence is not sufficient to be if before the surgery for patients with intracranial lesions, neuro-oncology patients, we use the peri-surgery device pneuma compression. That means that there should be enough of such devices, 5 or 7 or 10, as many as there are patients to have surgery for. Well, we don't have that many, frankly speaking. Well, this is far from reality. Now we have 2 devices. However, we are happy. Since patients, some of them are staying at the hospital for a long time, they are immobilized, they're elderly, and that increases the risk of thromboembolism. If hopefully we meet next year, I'll tell you about complications in anesthesiology when after the surgery there's a there may take place the thromboembolism. That's quite dramatic, especially in the intra-operation period. Now we'll talk about the 3 gamma cardial reflex in surgery of the skull base. My best regards to one of the members of the Presidium, my dear distinguished Dmitry Gulaev. This is related to your topic. So what is it, the hemorrhagic reflex, and why presentation should be dedicated to that? The skull base is the part of the presentation that Dmitry Gulaev knows very well about. Dendiv in the 1950s started the study of the topic, but only modern methods of device diagnosis and plastic surgery and microsurgery enabled us to remove bigger tumors at the skull bases. Of course, anesthesiology had to be improved to assist and intrasurgery monitoring. Otherwise, you can't remove big tumors with such comprehensive location. Development of neurosurgery, the development of devices, of philosophy, of drugs, and of the science of anesthesiology. Hence, the results are better, much better than some 20 or 10 years ago. And the results are positive regarding the oncology and function. Hemorrhagic reflex reflects the connection between brain and heart, and it's of vital importance, not only from the practical point of view, but from the point of view of science as well. We analyze such events, and it's quite an important event. Thus, step by step, we learn about neurobiology of the process and diverse regulation of hemodynamics system. And we learn how the organ and cardiac autoregulation and local perfusion change. These are difficult terms, but they testify the fact that heart and brain are closely connected. There's autonomous regulation, sympathetic and parasympathetic part of the connection. And when the surgeon impacts the structures, this reflex may be started. Anesthesiologists were the first to discover that yet in 1988, and they named it Trigeminal reflex. The events that develop in case of direct impact on the nerve. And this nerve innervates the scalp, the face, and all the anatomic intracranial structures. And the reactions like bradytachy, arrhythmia, and asystole that are registered are closely related to this registration of three-fascial trigeminal reflex. The physiology of and pathophysiology of the reflex was to be done with the patient during the surgery. How do we monitor and scan him? That's hypoxia, trichocapnia. That's what may happen. And these reflexes most frequently take place in younger children. If anesthesia is not sufficient, by the way, local regionary anesthesia, the block of the exits of the trifacial nerve works great. And it demonstrates the limitation of the development of this reflex and provides the threshold of safety when we don't see reactions like arrhythmia that may cause the atrial fibrillations. And we think the same with Dmitry. We have the same position. It's very good to have it during the neurosurgery. Different depth of anesthesia also impacts the frequency and aggressiveness of these episodes of the mentioned hemorrhagic reflex. Systemic drugs, analgetics may impact the hemodynamics. All this definitely pays a tribute to the peri-operation events, peri-surgery events that were registered and named since 1988 the hemorrhagic reflex. We mentioned the trifacial nerve. Now let's discuss the reflex. What does it mean from the point of view of neurobiology? You know that a trifacial nerve innervates the eye, the anatomic structures of the eye, the mandibular branch, the maxilla branch, and all of them are coming together in the node of Gusser. When the ophthalmology is performing a surgery on the eye, many doctors understand that quite often in ophthalmology we observe the asystole and other heart arrhythmias. That's due to the manipulations on the muscles of the eye. Why that? Due to that encephalic reflex. It's because we excite the trifacial nerve when doing that. The branches, the periphery branches of the trifacial nerve. And that's a classical polysynoptic reflex. Quite an arc, a normal arc. If reflexes are strong, then amylolytics atropine may be used to stop the reaction. There are other options of the reflex. Some of them exist since childhood, since birth. When a child is born, we put him into the water and he stops breathing. That's the trigeminal respiratory reflex. The essence of the reflex is to stop breathing and to bring down the heartbeat rate if a person gets into the environment where he can't breathe as the protective reaction. And now talking about anatomy, starting from the node of Gusser, from the trifacial nerve up to the roots that get out of the trunk and the nuclear. Look at the picture. There exists an intranuclear connection between the nucleus, sensory nucleus of the trifacial nerve, that's figure 3 on the image, and the motor nucleus of the vagus nerve. So this is really a switch of connection in the trunk between the sensoric nucleus of the trifacial nerve and the motoric nucleus of the vagus nerve. See, it happens instantly, and the heartbeat may be changed up to asystole. That's how the trifacial nerve reacts to the excitation, starting from the Gusser node. That's a central reflex. In our hospital, we never worked, we never conceal the events during the surgery that may be used as a material platform for education of the following generations of anesthesiologists, for the youth. Why should we conceal what happened to the patient? Yes, he continues to live on during the surgery, but one should conceal such reactions because we are using additional drugs. The main thing to do is to inform about it, the neurosurgeon, immediately that these reactions do take place. The ones that like the loud beat of the monitor, I believe that's an additional stress factor. The neurosurgeon shouldn't be bothered. He has a difficult enough task. He needs to perform the surgery and to improve the quality of life of the patient, while we should minimize the bad events, the adverse events. And if the reaction is very strong, if there's asystole, then we should act, and the resuscitation manipulations shouldn't be concealed as well. What do we observe in case of such a reflex? Well, there may be arrhythmia, heart arrhythmia, or there may be two options. Either the blood pressure goes down and there's bradyarrhythmia. That's the worst option. Of course, it goes away because we do our work. We introduce noradrenaline and atropine. However, there exists the first kind of localization. It happens that when the lesion is removed by the neurosurgeon, there'll be the secondary, the repeatability. They will start the repeatability of these reactions. And in such cases, we need to take measures that limit the strength of these reactions, but we can't avoid them, no matter how deep the anesthesia is, because this is the heart of the brain. May I put it this way? Because these reflexes take place due to the impact on the root of the trifascial nerve. And subtypes. The central periphery, next to cardial, maxilla, and mandibular cardial, when our dear colleagues, the facial surgeons, do the transfacial surgery, we can observe different reactions, peripheral and central, if big intracranial lesions are removed. Respiratory, that's mainly related to physiology. That's the diver's reflex. Well, that's it. The node of Gastrov, that's the first point from where these reactions develop. Where else do we encounter such reactions? In case we have the transsphenoidal surgery, if we remove the adenomas with the transsphenoidal axis, there may be arterial hypertension, and anesthesiologists, young ones, make a mistake if they believe that this fast neurosurgery, well, no matter minimum invasion through the nose, nothing serious, but the level of anesthesia has to be sufficient to provide neurovegetation stabilization of such kind of surgeries, because this is the skull base surgery, and after it there may be a cascade of humoral response if anesthesia is not sufficient. We may even have a bleeding which is not related to surgery but rather to systemic reaction of the body, to the aggregate condition of blood.
So when we have trigeminal decompression, surgery of Janet, it's very interesting to observe such reactions. If you see them and you understand where it comes from, it's good already. And when you have trigeminal schwannoma, it's huge, and it's before the surgery and after the surgery. And you need to seriously analyze the condition and what's going on. And the operator and the surgeon, they realize that you cannot avoid these reactions. You need to, when you try to think about what the prognosis is, then the situation in reality might be different. You start to work with the patient. So malignant tumors that can be removed in this way, then the reflex demonstrates itself, and young cardiologists, they shudder when they see what's going on with the patient when he has this manipulation. When there were breakages in the neck of the vasc, we also observe trigeminal reflex and then sleeping artery magistral vessels. To avoid vasospasm is in the future related to ischemic, we use intraoperational drug substrate antihypoxant that works really well, and it's patented, and a large series of patients has undergone it. So this is how we draw these conditions in the patient's cards. So the treatment, if this reflex is steady and it repeats itself, it means that the period after the surgery, it will be so the patient will have complications, and the particular methods and methodics should be implied because the patient doesn't wake up. We use opioids, alpha, and it needs to be really individual way of treatment. Sometimes there is a metabolic syndrome. Those patients who during the surgery have given abrupt reactions such as trigeminal reflexes and neuromonitoring also showed the irritation of stem, then you need to have a prolonged stabilization. Conclusions, I think I don't have more time, and I'm running out of time, and I'm going to try to answer your questions. Thank you very much for your attention. Dear colleagues, do you have questions? Thank you very much. So we have a lot of women today in this section. So we're going to proceed with epilepsy. It's a topic in vogue that everyone wants to take up with it and to operate thousands of patients. So what are particular characteristics of MRI imaging with the epilepsy, of patients with epilepsy? I believe that this is the main aim, to see the substance, to see what you can't see. Yeah, when you need to see what you can't see, you actually feel uneasy, because functional neurosurgery, it's surgery of a substance, and here we are lacking the substance. Yeah, there are X-ray doctors, MRI doctors. So, dear Presidium, Dmitry Alexandrovich, dear colleagues, not only addressing young colleagues, but also experienced colleagues, this presentation is not addressed only to young surgeons, but also to experienced neurosurgeons. They're not here, but they are present online. Focal cortical dysplasia. So what is it? We need to recall what it is. FCD. It's focal cortical heterogenic group of focal malfunction of cortical mantle related to the lamina of the cortex. It was first described in 1971 by Taylor and Falconer in histologic sample. And it's a common reason of refractory epilepsy in pediatrics, children up to 3 years old of age, and 80% of cases. So, and it's 30 to 40% of cases in adults. So this is a classification, Palmini classification. You see that lamina is broken, and neurons break cortical border, and they place themselves in white substance. We need to realize it in order to understand the pictures in patients. 1B, it's CITO, architectural distortion, and it's giant neurons. 2A, it's heterotopic neurons in white substance, and 2B, it's balloon cells, Taylor cells. Palmini classification dating of 2011, it's Bloomke classification. The difference is that there is the third group introduced. Can you see where I'm pointing at? So the third group of focal dysplasia, it's going in combination with other pathologies. So you see three types, A, B, and C. So what kinds of focal dysplasia we have? It can be gigantic. It can take the whole lower part of hemisphere. It can be multifocal, and it can be just a tiny millimeter of malfunction. And it demonstrates itself in different ways. There are huge forms that can be seen in MRI, normal MRI, regular MRI images, and for others we need a super sensitive MRI. First A type, it's a temporal dual with the hippocampus sclerosis, then extratemporal 1B, and extratemporal. And in order to define it, we need to use histological material, and it's only some of the types have pathological image in MRI. In order to visualize structural epilepsy, we need to produce a high-quality MRI, but we need to perform MRI screening. In our center on 6th Soviet Street, we have a serious innovation. That is, we have two epi-protocols, epi-protocol 1 and epi-protocol 2. The doctor, who is in charge of treatment, he might select the program for an individual patient because he knows the patient. And over 10 years we have used this program, and the thickness is of cross-section is 1 to 2 millimeters. This is the protocol 2. We have introduced so-called harness protocols. These are international protocols that Anti-Epileptic League has recommended in 2019. Sagittal protocol, space dark fluid core, so different types of cross sections to see gliosis zones. So what is the super power of this program? The protocol 3 is 3D T2 transversal surface cross-section, transversal cross-section 0.6 millimeters. So each millimeter is cut and scanned by 2 cuts. So the scanning takes up to 45 minutes. So the whole time for this screening is 1 hour 45. They use combined anesthesia and the mask because no person can be still for such a long period of time. It's the magnet field that is even to have a quality image. So if we compare epi-protocol 1 and epi-protocol 2, T2 transversal with the thickness of cut 2 millimeters, T2 with a thickness of cut 0.6 millimeters. Look at the program. It's like Brabant lace. It's thin work. You can see all the fossa, all the cortical modular borders. Each gyrus is seen, and there is no gyrus that is not seen in this program. The next protocol is flare protocol. It belongs to harness protocol. So before the cut was 2 millimeters, and now it is T2 space with 1 millimeter cubic voxel. And these programs can be introduced to neurosystems. It influences the MR signal, and you see glueus better. And so before it was the cut 1 millimeter, and now it's 0.8, 0.8, 0.8. And these are the main protocols to visualize focal dysplasia. So the second type dysplasia of second type, MR. Focal thickness of cortex. The pattern of the cortex is changed. The changes of signal from cortex. Cortical modular demarcation is not sharp anymore. It's not there. Then the increased signal from white substance related to glueus. And then let's see the pictures for each condition. So the first image, 1 millimeter is the thickness of cut. Hypertensive signal, it's better seen on the flare. So the zone is close to cortex. On the previous MRIs, it was described as point of, so it's sagittal cut. We see thick, changed, modified cortex with a high MR signal. Demarcation is not clear, and under the cortex we see glueus zone with incorrect form. But on corona picture, we see that it's all the mantle of the brain is pieced by this. It goes along the white substance and goes to the side lateral ventral. James Barkovich has described this transmental symptom in 1997. If X-ray doctor sees this picture, he doesn't need histological picture. He can say that it's focal cortical dysplasia type 2, Taylor. So in histology we see this picture in a different way. So here, T2, Taylor dysplasia. So we have this program that I'm advertising. It's thickness of cut 0.6. It's an amazing quality of imaging. Believe me, this is the zone of dysplasia. We see thin, deformed cortex. The signal from part of the cortex is low. The signal, for some reason, the zone demarcation line of the zone that is damaged is seen clearly. And in white substance, we see glueus zone. On corona cuts, we see the zone that is damaged and glueus that goes in thin line until the venter. So the first observation, the second observation. First, transmental symptom and transmental symptom in the second image. It's related to neuronatal migration. So this is how they moved. Neuronal migration. This is the process of the movement of neurons. So it's Italian pine, pinea, where cortex is dysplasia cortex, and the stem of the tree is a transmental syndrome. So this is the example. Next example. This is dysplasia zone. You see the size of it? This is precentral gyrus of the coronal flare. Gliosis zone goes on until the venter. We see the transmental changes, degeneration, and transmental symptom. Then demarcation is not clear, and the famous transangular zone. One more example of focal cortical dysplasia. Transmental changes are not there, but the gyrus is straight, it's abnormal, and there is no clear border between the white substance, and there is a zone of high signal. So we prove this in all different cuts, and fraction mesotropy is also damaged. A separate pattern that is mentioned in modern literature is DNA of the gyrus, of the fossa. But on the bottom, we see a small area of a changed MR signal. It's some round growth, the fraction anisotropy of diffusion. So the pattern is this root veggie, taking into consideration that is a spring. MR picture of dysplasia of the first type. So we just spoke about the second type, and now we go to the first. So if it's temporal dysplasia, it goes together with hippocampal sclerosis. So it's a dual condition. Then corticomedular border is not there, and the signal of subcortical white substance is high, and then segmental and frontal hypoplasia with atrophy of reduction of volume of white substance. It's one of the main symptoms which you need to pay attention to. Volumetric changes emerge, sometimes abnormal pattern of fossa and gyrus. And here's the pattern. Here we don't see the change in the signal. Parasagittal cortex is thick. Do you see it? The signal is normal, but corticomedular demarcation is not clear. There is no change of signal. It's a very difficult case because when MR signal is the same, the doctor might hyperdiagnose because the cuts have different angles in relation to cortex, and it might be a partially voluminous effect. It's a symptom of sfumata. Leonardo da Vinci, you can see in the Hermitage Museum, his paintings that we have, two Madonnas that are made in sfumata technique. So it's unsharpness. Now we see temporal focal dysplasia, reduction of white substance and of the volume of the lobe. And you see the thin cortex, corticomedular border is not clear. Is not. This dysplasia of the first type is a hidden pathology. Up to 50% of it are not revealed by MRI, and they can be compared to an iceberg when we see the top, and we don't know how big the bottom is under the water. So if we know the cases of unrevealed dysplasia, then it's this type. So this is the protocol number 2. We see focal dysplasia, we recognize its characteristics, and there is sclerosis of hippocampus. We have sagittal reconstruction and coronal reconstruction. Basal lobes are also destroyed. So dual pathology. Focal dysplasia is takes place together with mesial temporal sclerosis or with ganglioma or other malformations. This example we've seen by now. So pathology Blumke, pathology 3A, IPSI, lateral hippocamp atrophy and gliosis. Blumke 3A is a classic here. Very often hippocampal sclerosis and dysplasia are hidden, but knowing that they are related, we are looking for them. So this is cavernous angioma, but in this case we see that we have also focal cortical dysplasia, that cortex has gliosis and the border is not sharp. And in the program SWI, we see that those cavernas are 3, not just 1. It's angiodysplasia. Conclusion. So focal cortical dysplasia is one of the most difficult diagnoses in MRI. In small forms, it can be revealed only in a high-resolution MRI, but they can be overlooked easily. The evaluation of the data should be done by the doctor specialist in epilepsy. Sometimes they bring quality images from MRI, but radiologist doesn't, X-ray specialist doesn't see anything. We need to reveal these conditions as early as possible, then we have big opportunities for treatment and better prognosis. One of the images has disappeared, but not a problem. So all the patterns, transmantle symptom, fossa symptom, dysplasia of the first type with no borders, and then two-faced dysplasia. It's a common combination. Thank you very much, and big thank goes to Dmitry. I have a lot of questions. You're welcome. First, how often do we see focal dysplasia in MRI when it is not associated with this structural epilepsy? So you mean that it's just a finding that we have by chance? Yeah. Yeah, every month I have some patients that say, I was just passing by and I wanted to have an MRI and there is something. No, you have symptoms normally. Yeah, there was a report, COVID-19 as a trigger of focal epilepsy. Scandinavia presented this report. It was one of the conferences that I visit. There was a man who didn't have any epilepsy. So when he underwent COVID, he has dysplasia, focal dysplasia. It was a hidden epilepsy, and COVID served as a trigger. But it's a rare case, of course, but the flow of MRIs is huge, a lot of patients, and we see different pictures similar to dysplasia, and we ask did you have epilepsy? Do you have this condition? No, but then we find out that he actually has epilepsy. And yeah, sometimes the pictures are not clear, so I cannot really define that easily. So there are no negative pictures, or we don't see them. I wanted to show this picture, and now it's back. It's my know-how. I have produced these lectures for epileptologists. Do you like them? So what was the question? Are there MR negative forms, or we just don't see them? There are false MR negativeness. It's related to the fact that MR screening is not performed on a good level. So even when we introduced 0.6 millimeter cuts and we have come back to the patients that we screened before, we discovered that we couldn't see some zones, and we decided to make new screenings for them. Then mistakes in interpretation, focal epilepsy. Epileptologist thinks that it's a structural case, and he thinks left temporal lobe. It's clinical, and everything is evident. We make a super MRI and nothing is there. We see nothing. So MR negative forms exist. Surely they exist. And focal dysplasia is responsible of the first time. Is responsible for them, more likely. It's Vollhausen, Professor Vollhausen says it. If it's not dysplasia of the first type, then what is it? Because a small, tiny tumor is going to be visible. Something else is going to be visible, but this condition is not visible. So MRI doesn't reflect it in any way. If there is no gliosis, no change in signal. So what are the ways to solve this issue? Actually, we are working on the limit of our possibilities. A 0.6 millimeter cut is one of them. It's post-processing also. It's one of the possibilities. It's computer post-production of MRI. Imaging, morphometrics, but for that we need to purchase special programs and stations, and they are costly, and we need to teach personnel, and it needs to be a database that exists in Zurich.
There is such a database, but to get this, you take normal people, and the diagnosis is very difficult. Well, there are no healthy people, underdiagnosed only. So one should use this in practice. Same as with hemorrhagic stroke, the epilepsy, there's another trend. Everyone needs surgery. Well, the results of surgery go down abruptly if they take the MR negative form. Of course, there are intradural electrodes and rectal SPECT. That's a very difficult and expensive method. Only at Pirogov Hospital they do it, but they use a syringe with a radiopharm drug. They watch the patient for 24 hours to get the seizure. Electrodural electrodes also have their drawbacks. I saw patients after the installation of electrodural electrodes. That's quite an impressive thing. There's bleeding at each zone of cortex. They install the electrodes. That's quite an invasive method. And it may in itself stimulate the development of cortical gliosis. After such electrodes, the MRI provides a horrible picture. There's another question. So thanks for the presentation. I'm a morphologist, and for 70% time of your presentation, I was quite puzzled. I tried to recollect all the PCDs I saw, but there's no difference in white matter gliosis of type 1 and type 2. I don't see it. Could you explain in more detail this symptom-specific symptom? Well, according to the literature, at this place, there's the local lesion of blood circulation in neonatal period, or the lesion of transport proteins. Neurons go along the branches of glia to form the cortex. And if there's a lesion, ischemic one, you see it's a pyramid or a triangle. Most likely, there's the lesion of neuron migration. Nobody knows the reason for sure, but later it forms the post-ischemic gliosis. Nobody knows for sure. What we see on MRI, there was no task to compare the gliosis at 1A. At 1A, it is absent. I was trying to recollect gliosis, non-gliosis. Maybe there is a bit of a difference, but there was no obvious difference. At VCD of the first type, one can see massive gliosis in white matter. There are images and MRIs when it's not small but massive. It occupies the whole region. But at FCD2, this is a local. The mechanisms are different. The VCD1 and 2 have different development mechanisms, and this is visible at MRI. Here there's a triangle. Later, a morphologist shall tell about epilepsy. There we see the total gliosis with the background of white matter reduction, atrophy. It's difficult for me to specify the morphocorrelations. I'm a practitioner at the front line. I'm not a scientist in the field, but at FCD1 in the temporal lobe, there may be gliosis, but it's different. We're talking about a triangle. That's a Markovitch symptom. It's our favorite American neuroradiologist. We are basing our work on his theory. It may be local or diffused, like on the MRI image. And comparison requires quite a scientific study. You have to compare the MRI data and the morphology. Thank you, Daria. Thanks a lot. The next presentation is the tragedy of perifocal zone of glioblastoma. Boris, you're welcome. You think it's time to arrange a break? Shall we make a break? What about the audience? Let's make a break. So let's meet back in half an hour. Yeah, can we make a break for half an hour? According to the schedule, it's from 12:30 till 1:30. It's already 1 p.m. So let's make a break for an hour or half an hour. I'm not sure, but our Serbian colleagues have planned their time as well. We'll have to make a break anyway, so the break should be over by 1:30. So we announce a break for half an hour. Let's meet back at 1:30 p.m. Moscow time.